Hello everyone, today we are going to talk about suturing of skin and subcutaneous tissue. This is a initial course for suturing the skin, and we are just going to talk about how to prepare for the suturing. The most important step is to identify which wound needs suturing and which wound needs something more than suturing, and that we'll discuss in another video. So you need to make sure that your patient is correct. You have got the correct patient, correct sedation or local anesthetic, you have made that decision. Then you need the correct personnel involved. That means you need a nurse who will assist you. You need to make sure that there is somebody who can help hold the child if required. Okay. The physical things which you need are as follows. You definitely need a sterile set for the suturing, and you need sterile gloves. You need syringes, needles to help give the local anesthetic and do the irrigation. You need antiseptic solution, you need the local anesthetic, and you need the sutures. To talk a little bit more about sutures, broadly sutures can be divided into absorbable and non-absorbable sutures, and almost always we would be using non-absorbable sutures for skin and absorbable sutures for subcutaneous tissue. The only places where we would use non-absorbable sutures for the surface would be mucosa and sometimes on the scalp and the nail bed. So once all these are prepared, you can begin your suturing. Now we'll open the suture set and I'll just show you what instruments are inside the suture set. Okay, so this would be your typical suture set. There would be some towels for wiping your hands after your hand wash. There would be a sterile drape. There would be cotton. There would be gauze. Okay, and the instruments might vary, but essentially what we are looking for are the three main instruments. That would be a Derf needle holder, some kind of forceps to hold your skin. They can be tooth or non-tooth. Please do not use big tooth forceps for skin because they can form little puncture marks on the skin, and scissors. So these are the three instruments which definitely need to be there for your suturing: the needle holder, the forceps, and the scissors. The other instruments can be used as required and as available. Okay. Now I'm just going to show you how to use the needle holder and hold the suture. Okay. So make sure, because the suture needles are sharp, make sure that you do not handle the suture needle. Okay. It should be a no touch technique. Okay. So usually the suture needle would come fixed to the package. Okay. It is usually in the same shape and the same size as shown on the package. Okay. The needle would be the same size. What you can do is you can use your needle holder to hold the needle, okay, and pull out along the curvature so that you don't have to touch the needle. Okay. Try to hold the needle around at 2/3, 1/3 mark along the curvature at the back aspect, so that you have enough room to cover tissue as well as enough place for the curvature to follow through. If you need to adjust the needle, make sure that you use your forceps to adjust the needle. Do not hold with your hand and get a needle poke. Okay, so that's how you would attach the suture needle. Now the next thing is how to hold the Derf needle holder. So once you have attached the needle, make sure your index finger is placed close to the needle, maybe about 2 centimeters away. That would give you better control of how your needle holder moves. Okay, and once it is done, it would be good to use your thenar eminence or your thumb to open and close the ratchet. Okay, if let's say you're not able to do that, you can always get the suture in and then open it with your thumb. Okay, so that's about how to hold the needle. Okay, now we can start our suturing. Okay, let's talk about toilet and suture. There are 4 parts in any procedure of toilet and suture. The first part is making sure things are sterile. sterile precautions. That includes washing your hands, wearing sterile gloves, keeping the area sterile. So make sure that your tray and your trolley are clean and there's nothing else cluttering the trolley. Make sure you drape the area quite well, clean and drape the area quite well. So that's the first part. The second part of the toilet and suture is to anesthetize. If you're sedating, even then it's better to give some local anesthesia to the tissue so that there's some pain relief at the end of the toilet and suture. The third part is wound irrigation. That's the toilet part of the toilet suture. So the most important bit in the toilet and suture is to make sure that you irrigate and clean the wound well so that the healing takes place well and there's no infection. And the last part is the suture. So let's go step by step. As you can see, I've already worn my gloves. Okay. Now we're going to clean the wound. Okay. So use the antiseptic of choice and make sure you clean from the center to the periphery. Okay. So make sure you have cleaned it from the center to the periphery. Obviously, the first thing to make sure is that any external dirt is taken care of. So if there is some dirt, some mud sticking onto the skin and the wound, you should make sure that that's cleaned up. Okay. Once the initial cleaning is done, you should please infiltrate the local anesthetic. You can use lignocaine with or without adrenaline, depending on the position of the wound. So while infiltrating the local anesthetic, try not to pierce through the skin, go through the subcutaneous tissue, okay, go parallel to the subcutaneous tissue under the skin, aspirate before you inject and try to inject it uniformly so that the anesthesia is equal on all sides. Okay. What I would recommend is about 2 ml for a 1 centimeter laceration, but if you can anesthetize with lesser, then you can use lesser. Do not use lignocaine with adrenaline for areas which have terminal circulation like fingertips, the ear cartilage or ear pinna. Do not use adrenaline for penis or any cartilaginous part like the nose. So the nose, the fingertips, the penis and the ear, please do not use lignocaine with adrenaline. Okay, now the local anesthesia is done. Now the next bit is the toilet or the irrigation. Usually I use a 10 cc syringe. One of the methods which you can use for irrigation is by using a cannula. Just cut off the end of the cannula and use that for irrigation. Again, think of it as 25 ml for each centimeter of laceration. So if it's a 3 centimeter laceration, you should irrigate with about 50 to 75 ml of the antiseptic solution. Make sure you clean all areas and irrigate the corners. Okay, so once the irrigation is done, now the next step is to inspect your wound. Okay, so use a forceps and try and inspect the wound. Just make sure that it is the same as what you saw initially. Okay, look at the bottom. Okay, so in this wound we can see that the bottom is made up of the muscle, that's the base. You can see the muscle there. Then the subcutaneous fat, the subcutaneous tissue and the skin. Okay, so identify the structures, look for any nerves, any veins, any open arteries, okay, and make sure that you're not injuring any of them. Obviously, if there's a bleeding point or a spurting vein, spurting vessel at this point, you can suture it off and make sure that you control the bleeding. Okay, so identify, open and identify first. Okay, now that is done, try and oppose the edges. So you should only suture things which are opposable in a outpatient and an emergency setting. Okay, so you should be able to oppose the edges reasonably well. There might be some tension, but the edges should be opposable. If let's say the edges are quite far apart and you can't bring them together, then it might not be amenable for a toilet and suture. Okay, so now we'll go on to the suturing. So like I said, for skin, usually we use non-absorbable suture. Here I am using ethylene 6O. Okay, ethylene 6O is what we normally use for facial injuries. For limb injuries, we can use Prolene, usually either 5O or 4O, depending on the location. For areas like shin, thigh, forearm, 4O Prolene would be better, whereas fingers and toes and the dorsum of the foot, 5O Prolene might be more suitable. So we'll first look at this laceration. So you can see that this laceration looks quite superficial. Okay, it is just extending into the subcutaneous tissue, not breaching the subcutaneous tissue. You cannot even make out the subcutaneous fat, or you can just about make out the subcutaneous fat. So this one would be sufficient to do just a single layer of cutaneous sutures. Okay, so evert both edges. Make sure you're suturing the correct. You're suturing it in the correct plane. Okay. Now, once you have put the needle into the needle holder, hold it correctly. Use your index finger to guide your needle. Okay. Make sure you hold the edge with your forceps. Usually, I would start the suture from the center. Okay. It's best that the needle enters the skin at a 90-degree angle. Okay, and then you bring it out. Okay. Okay, so there are several things which you need to consider while doing the suture. Okay, the first thing is that the entry and the exit, you should try to keep it equidistant from the laceration. So if, let's say, there is about a millimeter between the entry and the wound edge, you should try to keep the exit about 1 millimeter away from the wound edge. Okay. Now the second thing which you need to do, which we need to make sure, is that the depth on both sides is equal. Okay. Do not make it very deep. Do not take too much of a subcutaneous tissue. If you're doing a cutaneous tissue, cutaneous suture, just keep it to the cutaneous tissue. Okay. And the angle, so try to get as much of the subcutaneous tissue into your suture. Okay. Now once this is done, and you have, now the next part is to tie the suture. Okay. Okay. So this is the free edge of the suture. What you do is you place your needle holder on parallel to the laceration, and then loop your suture around it, and then bring the suture to the other side, the free end to the other side of this wound. Okay, let's do that again. You keep the needle holder parallel to the suture, parallel to the wound, loop the suture around it towards the wound, and bring the free edge towards the other side. Okay, this will make sure that your knot is squared. Okay, and it will decrease the chances of the knot slipping out. Okay, we'll do another suture on this same one. So make sure your sutures are not too close together, because that will cause the skin to pucker a little bit. Let me show you what I mean by puckering of the skin. Okay, so let's say you have taken this suture and you decide to take a suture which is very close to the first suture. Okay. So you can see that the skin sort of bunches together here. You wouldn't want that skin to bunch together there. That would cause the scar to become worse. Okay. So each centimeter wound, this might differ according to different people, but each wound of 1 centimeter would require about 3 sutures. Okay, and maximum 4 sutures. Try not to keep it too close to each other. The next thing to remember while suturing is to make sure that you do not tighten the knot too much. Okay, the tension on the skin should not be very high. If obviously the tension is very high, the subcutaneous tissue will break down and the scar will not look good. Okay, let me show you what I mean by a very tight knot. Okay. Okay. So can you see that here again the skin is bunched up? Okay. So the problem with such a tight knot is that the vascularity to the skin edge is compromised and the skin edge might dehisce and die, okay, which eventually will make your wound split open when you take out the sutures. So just make sure that your sutures are not very tight. Okay. The tension should be just sufficient to bring the edges together and slightly evert them, but they should not get the edges scrunched up. So for simple lacerations like we see in the emergency department, use interrupted simple sutures after good irrigation, so that in case there is some infection, you can remove one suture at a time. Continuous sutures would be more suitable in a clean incised wound. Once the wound has been closed well, make sure you clean the surface well and do a appropriate dressing. Now let's go on to a deeper laceration, okay, like the laceration we saw before, which is quite deep and goes beyond the subcutaneous tissue, beyond the subcutaneous fat, and almost enters the muscle layer. Okay. In this kind of laceration, you would require to do sutures which are in layers, because if you just do a skin suture, the bottom part of the wound would not approximate, and that would give you a scar which will contract, and that would not look good. So let's see if I just do a cutaneous suture for a laceration which is deeper than skin, deeper than dermis. Okay, so I'm just doing a skin suture instead of doing a layered suture. Okay, so now that I have done the suture, what you can see is the bottom part is not approximating. Okay, the subcutaneous fat, the subcutaneous tissue stays apart and only the skin comes together. So eventually when the healing takes place, there would be a gap there and the scar would involute, and that would give a bad scar. So it's always better to do it in layers. Okay. So as I mentioned before, for subcutaneous tissue and inner layers, we use an absorbable suture. Here I am going to use a Vicryl 6O. You could use Vicryl, you could use monocryl, any of the absorbable sutures. Usually for facial injuries or head and neck injuries, we use Vicryl 5O or Vicryl 6O for subcutaneous sutures. Okay. So in this wound, I don't really need to suture the muscle, because you can see that the muscle is intact. There's only a very small cut there. Okay. There's no use suturing the fat. The fat will not hold together, and there will be no healing tissue on the fat. So there's no use stitching the fat. What we need to suture is the subcutaneous tissue. So what I want you to understand is this is where the subcutaneous tissue starts, and this is where the epidermis and dermis start. So this white bit is your subcutaneous tissue. So to do a subcutaneous suture, okay, first you need to evert the edge well so that you can see both ends of the subcutaneous plane. Okay, enter at 90 degrees. Okay, and in from so deeper in, superficial out. Okay, so deeper in, superficial out. Then on the other side, superficial in, deeper out. This way you can bury the suture. So again, evert the edge, make sure that you can see the subcutaneous plane well. Approximate the suture so that you are going in the right plane and the right point. Okay. then bring it out. Okay, so that's how it should look at the end. You have to have a deeper, superficial, deep, okay, and then bring your subcutaneous tissue together. Okay, let me go through that again once more. Suture once more. Okay, so invert the edge, make sure you are seeing the plane well, enter at 90 degrees, okay, deeper in, superficial out, okay, that's the first side, okay, then you make sure you approximate the edges well, and invert the edge, okay, and again superficial in, deeper out, okay, we go in this way so that we can bury the suture or bury the knot essentially, okay, so this is how it would look at the end of it, okay. Okay, so once your subcutaneous tissue is together, then the tension on the epidermal tissue or your surface sutures is much lesser, and then you don't need to pull hard on the skin. Okay, so now that the subcutaneous tissue has been done, subcutaneous suture has been done, again like I mentioned about this skin suture, go equidistant, enter the skin at 90 degrees, try and make sure that you're coming out equidistant from on the other side from the edge, and square the knot. Okay, so that's about suturing doing a subcutaneous suture as well as a skin suture. After the suturing is done, make sure you dispose your sharps without fail and clean the wound well and do a appropriate dressing. And the patient should be reviewed in about 3 to 5 days to make sure there is no wound infection. And the general advice is to keep the dressing dry so that there is less chance of wound dehiscence.